Substance abuse disorders, SB 700-11.
This last
In this lecture, we'll do a brief overview of adolescent drug abuse trends and principles of effective drug abuse prevention. We will build upon the assertion that there is a fundamental difference between early onset non-normative drug misuse and normative drug and alcohol use. These two phenomena do not necessarily differ in terms of quantity frequency of drug and alcohol use, so we must look beyond drug use patterns to identify the core differences. These differences are to be found by referencing the vectors of risk elucidated previously in our discussion of substance abuse as a developmental phenomenon. Here's a fun fact about adolescent substance abuse. About 60 to 70% of young people who misuse alcohol and drugs in high school and college terminate the problem prior to hitting adulthood. This temporary state of affairs may end as a function of, quote, maturing out, or as Heyman 2013 notes, may simply reflect the time-limited nature of most substance abuse problems. 30 to 40% of adolescent abusers go on to a career of drug abuse that continues into adulthood and that perhaps may mark most of their adult life. How do we predict who belongs in which group? The 70% or the 30%? It is not predicted by quantity frequency of drug use during the teenage and young adult years. The best predictors are the presence of the high-risk factors discerned from our study of somas, sons of male alcoholics, the developmental precursors to early onset enduring substance abuse. The assessment challenge is to figure out if we are dealing with a normative or a non-normative high-risk user. All may be high-risk users, of course, and all do not differ in terms of quantity frequency of use. The categorization has more to say about long-term course versus short-term potential for alcohol and drug-related harm. You cannot accurately discern which individual is going to go on to a career of continued alcohol and drug misuse versus which individual is going to stop their use. You can't discern that by their drug abuse patterns. You have to look beyond that to some of these endophenotypic factors. Here, once again, is the tripartite breakdown of forms of alcohol and drug-related problems: intoxication-related problems, health problems, and social problems. Long-term health risk use may lead to health problems, which include manifestations of craving-level drug dependence, health problems. Short-term use often involves intoxication-related problems, things that occur while the individual is under the influence. Status offenses fall in the category of social problems, and there are certainly many status offenses related to adolescent and young adult drinking. When working with youthful individuals, both those who present with normative and non-normative drug use, the first challenge is to reduce rates of intoxication-related harm. To reduce rates of intoxication-related harm, including overdoses, car accidents, unwise sexual encounters, violence, etc. This challenge pertains to all high-risk users, normative and non-normative. A secondary challenge is the early identification and intervention with the early onset non-normative users, those kids most likely to continue on to a more lengthy career of drug misuse. These are the somas and the non-somas who manifest soma-like traits and vulnerabilities, particularly in the areas of cognitive dysregulation. Simply put, one needs to help all kids get through the high-risk period without having a tree hit their car, and also identify those kids who, having survived the high-risk period of adolescence, remain at risk for disorders of dysregulation, including substance abuse. Please take a look at the Kraft version 2.1 documents on Canvas. Craft was revised in 2020. In addition to the administration manual, you will find the revised Craft, which now includes a screening for nicotine use, which is actually not necessary, but extra and a good addition. The coolest thing about the Craft is that even if one does not drink and drug, spending time in a vehicle with an intoxicated driver is deemed a salient risk factor. One might add the Craft to the array of assessment instruments suitable for youth, including the audit, the DAST, and the DO-CR.
Trains are fun, but don't be fooled. Safety first is a mighty fine rule. Keep your eyes open and promise that you'll be sensible, be smart, and be safe.
Okay, so we have a few challenges in addressing youthful substance use and misuse. Helping kids stay healthy and safe during the high-risk period of normative adolescent and drug and alcohol use, and also addressing the needs of those at greater risk for enduring substance abuse difficulties. Furthermore, we need to develop and implement programs that address the cohort as a whole, i.e. providing information to both high and low-risk adolescents, and to do so in a manner that resonates both with the low-risk users, those least likely to manifest an alcohol or drug use problem, and also with the high-risk users, those kids least likely to respond to an abstinence-focused message. Thus, we have 2.5 goals: supporting abstinence in those who have not started to use intoxicants, basically moving the normative curve to the right protects the whole population in terms of expectations and norms, normative versus non-normative use issues here, and also decreasing problematic use patterns among both subsets of high-risk users, the normative high-risk users and the non-normative high-risk users. How do we define high-risk use, by the way? Think of things like binge drinking, drinking, drugging, and driving, drinking and drugging at the need level of involvement, etc. Youth-oriented prevention, the traditional approach. Drug use is drug problems, maintaining abstinence above all, etc. So how has this challenge been addressed traditionally? Not very well. Traditional youth-oriented prevention programs have focused on the articulation of messages that are geared specifically to the developmental level of the child and that conduce abstinence. Any use of any drug is defined as problematic use. This can be confusing and anxiety-producing in children who may look at their parents' use of caffeine, nicotine, sugar, etc. as signs of drug abuse and addiction. This negative framed message is often effective in prompting continued abstinence in those kids least likely to initiate drug and alcohol use. However, in equating any use with problematic use, the classic negative frame prevention program does nothing to engage the kids who are already using intoxicants, nor to address their needs, which are on the realm of avoiding harmful use in the context of the intention to continue to use alcohol, tobacco, and other drugs. The classic youth-oriented model promotes continued abstinence in those least likely to experiment with alcohol and drugs, even in a normative way. The classic youth-oriented prevention program does nothing, repeat, does nothing to address the needs of non-normative high-risk users, and in a more general sense, of any kid who has initiated alcohol and drug use and is not likely to respond, at least initially, to an abstinence-only outcome-oriented message. The classic model of just say no and drugs is bad for you uses a top-down parental approach to scare kids into maintaining abstinence. The message does not effectively convey information, nor does it function as a message that can be carried forward from, say, third grade through middle school into high school. Furthermore, as a negative framed message, it does nothing with regard to addressing the concerns or motivational issues of the kids who are most likely to initiate drug use. Any message that conjoins problematic drug and drug use per se is going to be ineffective in any of these high-risk groups. A drug is not a drug is not a drug. If your parent vapes nicotine or does an occasional edible, they are not necessarily in the same category as the crackhead on the corner. Click and listen to the South Park version of Drugs is Bad for You.
Drugs are bad. You shouldn't do drugs. If you do them, you're bad because drugs are bad. Okay, it's a bad thing to do drugs, so don't be bad by doing drugs. Okay, that'd be bad.
Project AIR. Project AIR was another attempt at youth-oriented prevention. Many of you probably engaged in DARE while in high school. On the positive side, DARE promoted increased rapport between high school kids and the local police. On the downside, Project AIR actually increased the rate of initiation and experimentation with intoxicants for two reasons. First, by asserting that many of your peers were doing drugs, DARE actually modified student expectancies regarding the normative nature of drug use, thus lowering the symbolic threshold associated with this. Two, by supporting student self-efficacy with regard to drug refusal, DARE actually empowered students to make autonomous choices, many of which were to try illicit substances. Scared Straight was another negative framed attempt at prevention. It also backfired because the pros of drug life, lots of money, lots of sex, lots of fast cars, great houses, great shoes, for those kids outweighed the pros of abstinence, such as piety, a lower paying, lower status, legitimate job, less sex, fewer sneakers. Click on the mouse to hear.
Do you think I would?
Yeah.
You're damn right I would. Are you ready to kill somebody?
No.
You're ready to do that monkey business you're doing on the street, though, aren't you? You're ready to hang out on the corner, though, aren't you?
Yeah.
Then you better be ready to kill somebody, because when you're in this place, you gotta kill if you have to. When you wake up in the morning, do you think about maybe I have to kill somebody today?
No.
When I wake up in the morning, I think about maybe I have to kill somebody. Do you think I would?
If you've not watched the SNL version of Scared Straight, please treat yourself to this. As a bit of an aside, the 21-year-old drinking age is an interesting phenomenon. Although it did not markedly reduce underage drinking, it did change the venue wherein kids drink and drug. Rather than drinking and drugging in the car, they moved to their bedrooms, the basements, and the backyards. This did a solid job of reducing underage harm by decreasing the rates of auto accidents and vehicular deaths. We'll talk more about the 21-year-old drinking age when we talk about harm reduction. So, if the youth-oriented prevention message is ineffective or counter-effective, what is the alternative? Lifespan prevention. In lifespan prevention, one starts with a message that has credibility across the lifespan. One does not tailor the message for third graders and then modify it for the sixth grader, etc. Information remains consistent if tailored to the cognitive and developmental capacities of the specific age groups. Drug classes are differentiated. A drug is not a drug is not a drug. Use is contrasted with misuse or problematic use. A Budweiser at dinner is not the same as a jug of hooch before work. Developmental norms are addressed with articulation of why norms and guidelines for kids are different than for adults. The concept of neurobehavioral development and the need to develop social communication skills, for example, are articulated. This rationalization of the status differences between kids and adults helps mitigate the 21-year-old backlash wherein people at age 21 go nuts with intoxication. Similarly, the freshman first semester away at college goes nuts with an alcohol and drug use backlash. High quality information delivered in a neutral manner with a focus on positive framing, the benefits of doing such and so, versus negative framing, drugs is bad, is also a component of lifespan prevention. The starting off points for lifespan prevention are with respect to alcohol and cannabis use, but there is a compelling argument to move quickly beyond this to opioids, ecstasy, and other intoxicants. It's clearly time to add mojo education to every middle school and high school health class. Lifespan prevention is a fundamentally an educational model to induce positive decision-making among kids. It involves information, messages that have equal credibility for adults, college students, high school students, middle school students, and also elementary school students, and of course, their parents. So this ends this brief lecture on issues related to adolescent substance